Hi, I am Dr. BharatkumarNara, and I am a senior consultant at Gleneagles Global Hospital, working in the Department of Surgical Gastroenterology and Liver Transplantation. As a part of our discussions, which we have been conducting in the past few months about various conditions in the GIT, today we will discuss about intestinal obstruction. As you all know, the GIT, which is also called gastrointestinal tract, extends from esophagus to the anal canal, and small intestines and large intestines form the major part of the GIT. In fact, the entire abdominal cavity, most of your abdominal cavity is filled with intestines. As I said, there are two kinds, small intestines and large intestines. On an average, an adult would have a length of 5 to 6 meters of small intestine, which can be like 15 to 20 feet long, and about 1.5 meters of large intestine, which is again about 5 feet long. So it's quite a lengthy organ, and it varies with age of the person, height of the person, and weight of the person, and in fact sex of the person. So coming to the functions of small intestine and large intestine, they are the ones which do real business for you, that is digestion and absorption of food. Along with that, they also help in absorbing electrolytes, minerals, vitamins, and also helps in formation of feces and transporting them out of your body. Apart from these basic functions, your GIT, your small intestines and large intestines, are filled with gut microbes. In fact, your large intestine is colonized with millions of bacteria, which not only help in fermenting the food and breaking down the food complex carbohydrates into simpler ones for absorption, but they also produce some gases, which you call in common terms as flatus. Apart from these, the GIT, especially the intestines, they also secrete hormones, which are essential for gut-brain axis and also for your day-to-day functioning of your body. In fact, the GIT itself is one of the first line of defenses for your body, where microorganisms or pathogens which enter into your body through food are killed and expelled out, so that you won't get affected by those organisms. Generally, the food you take or you eat would take 3 to 5 hours to transit from small intestines into large intestines, and from there on about 12 to 24 hours to get expelled out. The food generally travels in your GIT like something which you can relate to something which is moving on a conveyor belt. So it is gradually transported from the oral cavity into the stomach, into the esophagus, and into the stomach, and then where the food gets digested, where the food gets broken into smaller pieces, and then these smaller portions of broken food enter into the intestines, where they are chemically digested and then get absorbed into your body. So this is a process which happens to every one of us daily. Presently, we are dealing with this situation of COVID, which has become a pandemic, and then each and every one of us is affected by this pandemic. Apart from the regular respiratory symptoms which you all know about COVID infection, the COVID virus can also affect your GIT, and then at least about 40% of the people who are infected with COVID virus have experienced some kind of gastrointestinal symptoms also, especially in the form of diarrhea and all that. So basically what happens is these COVID virus, SARS, which is also called as SARS-CoV-2 virus, it affects your goblet cells, which is the primary target for them, goblet cells in the intestines. And then from there on, they produce multiple, they act on the multiple receptors, especially AC receptors. And then from there, they produce multiple hormones and multiple inflammatory markers, which are then carried throughout the circulation and then affect different organs of your body. So, as I said earlier, your GIT is again a first line of defense, forms first line of defense mechanism for your body. So let us talk about this topic in specific. So what I was intended to do today is, I'm intending to do today is talk about intestinal obstruction. When there is interruption of flow, that means forward flow from one part of the intestines to the other, it is basically called as obstruction. So the food wouldn't propel forward. Instead, it would get either blocked there, or it would form, it would express itself in various different symptoms in different ways. So basically, when the intestines don't allow the food to pass through, it is called intestinal obstruction. So it can happen either in the small intestine or in the large intestine. So the clinical symptoms, the kind of symptoms which you experience when you have this kind of obstruction depends on the level of obstruction. Like if the obstruction is in a small bowel at a more proximal level, or at a small intestine at a more distal level, or if the obstruction is in large intestine or in the rectum. So depending on the level of obstruction, the symptomatology differs. So generally, in a general way, if I have to explain it to you, generally the patients with intestinal obstruction would experience abdominal bloating, distension with vomitings. These two would be the most common symptoms for any patient who is experiencing intestinal obstruction. So the patients would vomit either food which they have eaten or food containing bile, that is greenish colored fluid which is part of your intestines. So patients would vomit either food or bile containing food, and they would have abdominal bloating or distension with severe pain and constipation or obstipation. So patients wouldn't pass feces or even flatus also, for that matter. So depending on the again level of obstruction and the severity of obstruction, the patients would experience other symptoms like severe abdominal pain with fever and vomitings, fever and abdominal distension with constipation and all these symptoms. So if I have to explain about this, causes for this kind of intestinal obstruction, there are mainly three causes which are more common. The first one is adhesions or intra-abdominal adhesions, which could be a part of post-surgical complication or naturally forming adhesions. So this is the most common cause for intestinal obstruction. Adhesions are nothing but tiny, thin, flimsy strands which form inside your abdomen, which would strangulate or entangle around intestine and cause a mechanical obstruction. So this can happen most frequently following a surgery. The time period following surgery can be any time, any length of the period. It can be followed by surgery immediately, or it can happen even after 10 years or 20 years also. So any person who has already undergone abdominal surgery and who experiences these kind of symptoms, the first thing we would think about the cause for these symptoms is because of intra-abdominal adhesions causing obstruction. The second most common condition which causes obstruction is malignancy or tumors. So tumors occurring in any part of the small intestine or large intestine, if they grow much bigger in size, and if they are bigger enough to occlude the lumen of the intestine, can cause obstruction. The third most common cause would be herniations. Herniations are protrusion of the small intestine or large intestine through a defect in our abdominal wall cavity. Wall of the abdominal cavity, and then that will cause a mechanical obstruction and then cause symptoms. Apart from that, there are many other causes which can cause obstructions, like foreign bodies or intussusceptions. Intussusception means the bowel will try to protrude itself into the next part of the bowel. That means the proximal bowel will try to push itself into the lower distal part of the bowel, causing mechanical obstruction. Or sometimes we call it as volvulus. Volvulus is a condition where the intestines get twisted onto themselves and then cause an obstruction. So there are various reasons where the patients would experience obstructions. Sometimes, especially in elderly people, old people, where the bowel movements are not brisk enough, or where the patients have a kind of hard or impacted stools, can also experience an intestinal obstruction. So the causes are many, but the symptoms are, as I mentioned earlier, the patients would experience similar symptoms in all of these conditions. But again, depending on the nature of the obstruction and the severity of obstruction, we need to adjust to the cause. Sometimes when the obstruction is so severe that it wouldn't allow any food to pass for months or for days together, the small bowel, the intestines would get distended so thinly that they would perforate, or there would be a rent in the part of the intestine, and then the fecal matter or the intestinal contents would spread out into the abdominal cavity. Or else sometimes the blood supply to that particular part of the intestine would decrease and then would stop flowing, and then that particular part can become gangrenous. Gangrenous in the sense, it would be without blood supply, the tissue would become denaturalized and devitalized. So that is called gangrene. So these things can happen with intestinal obstruction. So majority of the people would present to an emergency department with severe abdominal pain and distension of the abdomen with vomitings. So what we do when we receive such patient is, first we try to clinically assess what is the condition, how severe is the condition, and how bad is the condition of the patient. So initially we try to resuscitate them by giving IV fluids, and then by giving some passing a Ryle's tube to relieve obstruction. So after initial resuscitation and initial attending to the patient initially by for initial improvement of the general condition of the patient, we would look into the cause for the obstruction. Generally, in these patients, a simple X-ray of the abdomen would show the reason, the cause, or the nature of the disease, the problem of the in the patient. So a simple X-ray of the abdomen, both erect and in supine position, would tell us kindly the level of obstruction and the intensity of the obstruction, and if there is any other complication like a perforation in the patient. So majority of the time, about 60 to 70% of the patients, the X-ray itself would give a diagnosis of the condition. And then if in case the X-ray wouldn't pick up any of these signs, maybe the patient has presented to the emergency department much earlier in the course of the disease, then we would like to get a CECT, that is contrast enhanced computed tomography, CECT of the abdomen, to look into the condition more critically and more intensely. So in that we can come to a conclusion like at what level of the intestines the obstruction is there, and the reason for the obstruction also. So these two tests are essentially the main tests which determine whether the patient has got an obstruction or whether he has got the grade of obstruction and the level of obstruction. So all these details would be very evident from these simple tests itself. So once you know that there is an obstruction and then there is a distended bowel and the proximal part of the intestines, which prior to the obstruction would be enlarged and the distal part would be collapsed. So once we know that, we try to resuscitate the patient. Once the resuscitation is done, we try to see whether the obstruction would get relieved on its own by placing an IV fluid and giving rest to the abdomen, in case the patient doesn't have any peritoneal signs. Peritoneal signs means when we touch the abdomen, the patient will have severe pain or will experience severe pain and tenderness. So that is when we know that the patient is having peritonitis. So if there is no peritonitis, we can give him IV fluids and pass the Ryle's tube, and then give some antibiotics and all that, and try to improve his general condition over next few hours or few days to see whether the obstruction can get relieved. Generally, in a case where in a patient where the obstruction is due to adhesions, that is surgical causes like previous surgery causing adhesions, would become better with simple measures like these. But then they may have a recurrence of these complications, these symptoms. So once we see that these same symptoms are recurring again and again in the same patient, then we would definitely intervene and do something to relieve the obstruction. Whereas in case of a native abdomen, a virgin abdomen where previous surgeries have not been done, we would definitely think again in a more serious cause for the obstruction rather than simple adhesions. So we would, as a surgeon, I would definitely like to intervene in those patients to see what is the cause of the obstruction and then correct it. So the surgical intervention, coming to the surgical intervention of these for these conditions, basically it can be done in two ways, whether it is an open laparotomy, depending whether it is open laparotomy or laparoscopy. If there is enough space in the abdomen to perform a laparoscopy, I would always prefer to do a laparoscopy to rule out the condition and then relieve the problem. But if the abdomen is so distended and then there is no enough space for us to operate laparoscopically, there is no other way to treat the patient other than to do a laparotomy. So once it is done, we know the level of obstruction and then we know the cause of the obstruction. So we try to resect that part of the abdomen, resect that part of the intestine, and try to anastomose the bowels again to make the continuity and for to allow the food to pass again to distal parts of the intestine. So this is what is briefly done in a case of intestinal obstruction. Occasionally, when the obstruction is so severe that the bowel becomes so thinned out and so thinned out that doing a primary anastomosis would be more detrimental for the patient, we would try to do a stoma. That means letting out the intestinal contents through a small opening in the abdominal wall through the abdominal wall. So we make a stoma there so that the patient's life is saved first, and then we can restore the continuity at some other point in the course of the events. So this is how intestinal obstruction would present, and this is what we do for an intestinal obstruction. So this is a surgical emergency, and whenever there is an obstruction or whenever a patient experiences these kind of symptoms, they should not hesitate to come to a hospital and then get treated appropriately. This is what I want to tell you today. We would again take up one more topic in the near future and definitely give more insights into various GI conditions which can happen to one. And I extend my greetings from my hospital and my colleagues at the hospital, that's Gleneagles Global Hospital at Lakdi-ka-pul, Hyderabad. Thank you.